It's a great honor to participate of this joint activity of the Argentine Association of Cardiology, the Argentine Federation of Cardiology, and the ACC. And I truly appreciate for being here. So I do not have any conflict of interest with this presentation. And as it happens in large parts of the world, in particular in the Western world, the main cause of death in Argentina is the cardiovascular. 1/3 of the Argentine population die or will die because of cardiovascular issues. Secondly, we have the angioplasties, the respiratory causes, and others, which are less representative from a statistical standpoint. As it happens in the rest of the world, cardiovascular fatal cases has been reduced in the last few decades, and it decreased by 41% since 1980 through 2015. Cancer and infectious diseases have decreased as well, and there was a slight increase of respiratory diseases. When we talk about prevalence of cardiovascular diseases, we see that Argentina has a prevalence of cardiovascular diseases similar to North America and Europe, Western Europe. And we can say that 4% of the Argentine population has cardiovascular disease, suffers from this disease. However, despite this similar prevalence of CVDs, Argentina has more fatal rate than the North America and Western Europe. Then in the debate, we could talk about the grounds for this difference, for this distinction. If we compare mortality in the United States versus Argentina, we'll see that 50% of the cardiovascular causes of death in both countries are represented by heart failure and coronary disease. The difference is that in the United States, most of the deaths are because of coronary disease, while in Argentina, there's a significant prevalence of mortality by heart failure and strokes. We could also debate this in the final discussion. The Carmela study, if not the most important, is one of the most important trials to research the prevalence of risk factors in Latin America. More than 11,000 cases studied in 4 Latin American cities: Barquisimeto in Venezuela, Bogotá in Colombia, Buenos Aires, Argentina, Lima, Peru, Mexico, the Federal District, Quito in Ecuador, and Santiago in Chile. And what they studied was the prevalence of classic factors for coronary risk and through the carotid echography. In the next slides, I will point out the prevalence, the differential prevalence in these 8 cities. For example, blood pressure, high blood pressure is headed by Buenos Aires. Hypercholesterol levels is headed by Quito, but very closely followed by Buenos Aires. Smoking, we have Santiago de Chile, which is first, followed by Buenos Aires. Diabetes, Mexico, out of the 8 cities, is the one that comes first. And obesity, also Mexico is first in this chart. And metabolic syndrome, Mexico comes first. I have the impression that all the cardiovascular attacks or affection prevail in Buenos Aires and metabolic in Mexico. The media of the carotid, Buenos Aires is headed, and this has to do with the high blood pressure indexes in Buenos Aires. Barquisimeto and arteriosclerosis comes first, and last, when we measure prevalence of high cardiovascular risk defined as above 20%, Buenos Aires comes first. This gives us a scenario where we are located here in our dear city of Buenos Aires versus other 6 Latin American cities. Another significant trial and study has to do with the SECAS project, conducted by the Center of Excellence in Cardiovascular Health for South America. This was published by the International Journal of Cardiology in 2015, and as from 2010-2011, 7,500 male and female adults were analyzed in Marcos Paz, Argentina, Bariloche, Argentina, Temuco, Chile, and Barros Blancos near Pando in Uruguay. And what they assessed was the prevalence of cardiometabolic risk factors by making a thorough questioning house by house. All the experience obtained so far, I would like to show this image. We can see 4 cities here that I mentioned before, and we analyze the number of individuals with at least 5, 6, or 7 risk factors. And we see that prevalence are very much alike. You can see the sector of patients with 5, 6, or 7 risk factors, and Marcos Paz and Bariloche in Argentina show a trend to have the lower percentage or the lowest rate out of this group. This is somehow contradictory with the Carmela results, but obviously Buenos Aires is one thing and smaller cities are different from the inner country. And the last part of my presentation will refer a comparison from prevalence and trend of risk factors versus these 2 significant surveys, 2005 and 2013. There was another one of 2009 because these are surveys conducted every 4 years. But we will analyze things from end to end. This is a national project sponsored by the Ministry of Health, and the first publication is in the Argentine Magazine of Cardiology of 2012, and the second one is on the page of the Ministry of Health. Let's see what we have here. The country was divided in 4 sectors or areas: Northeast, Northwest, Cuyo, the Pampean region, and Patagonia. And here we're going to see how we compare the prevalence trends of risk factors throughout the last 8 years. Low physical activity. It increased by 18%, and more than half of Argentina do not make or do not have physical activity. Consumption of at least 5 pieces of fruit or vegetables. This has not changed in the last years, and prevalence is low. More than 5% of people consume at least 5 pieces of fruit or a day. Use of salt on the table decreased by 36%, and this is one of the beneficial facts of this survey. There were some publicity and advertising campaigns sending messages from the national, provincial, and municipal authorities about removing salt in restaurants, just to mention a few measures.
The addition of overweight and obesity increased over 20%. Over 60% of Argentines are obese or have excess weight. Another good answer was reduction in smoking. Less 15% less smoking, and this, of course, probably had some incidence, the legislation, prohibition of smoking in certain places, etc. This is the number of people that measure their BP. It increased 20%. Over 80% of individuals get their blood pressure measured. However, despite this increase in BP control, the prevalence of hypertension did not change. It's over 1/3 of the population. There is also an increase in the number of people that have their cholesterol measured, 6%, but hypercholesterolemia improved by 7%, increased by 7%. So when they get measured, we discover that there is a high prevalence. This is a hypothesis, of course. This is the number of people that get their glycemia measured. This went up by 10%, but also there was a 16% increase in the diabetes prevalence. And this goes hand in hand with what's happening worldwide, whereas there's increase of metabolic disorders and diabetes rates and metabolic syndrome, overweight and obesity have increased not only in Argentina, but this is a worldwide phenomenon. The last slides derive from the Risk Factors National Survey. And what I'm attempting to show are the geographic differences. When you look at the number of people that get their cholesterol measured in different provinces throughout the country, these are the two extremes, the city of Buenos Aires and Jujuy. Much less people in Jujuy get their cholesterol measured compared to the city of Buenos Aires, the capital district. And the prevalence of hypercholesterolemia is also quite different in different provinces throughout the country. There is a huge difference of hypercholesterolemia in Catamarca and San Luis, for example. And the measurement rate for glycemia, it's quite different in Tierra del Fuego, which is the place where most people get measured for glycemia. And Chaco has the least prevalence in measurements of glycemia. And diabetes, well, Jujuy has half of the prevalence compared to other provinces. And of course, the National Survey of Risk Factors has also shown other things, and this derives from the work by Ferrandi and collaborators. And they analyzed the differences from the socio-economic viewpoint and also the educational viewpoint. And you can see that obesity, when you compare people that have completed elementary school compared to university students, obesity doubles those who have higher education levels. And hypertension follows the same path. It is much more frequent to have hypertension in low-income level populations compared to those who have college studies. And hypertension, the same. If you stage the population in high, middle, and low, hypertension is higher in low-income populations, 41%, compared to 27% in high-income populations. So this shows that Argentina is a very heterogeneous country regarding geographic distribution as well as socio-economical and educational and cultural issues. So the conclusions are the following. The first one, cardiovascular risk in Argentina is quite high. Second, in between 2005 and 2013, there was a trend to smoking reduction and less salt consumption, but an increase in low physical activity, overweight, obesity, and diabetes. And also there's outstanding heterogeneity in the prevalence of some risk factors, mainly cardiovascular risk factors, based on geographic region, education level, and socio-economical level. Thank you very much.